Hi, I'm Bruce Murphy. I'm the CEO of Arkansas Heart Hospital. Please watch this for a sneak peek of our Heart Summit.
Hi, my name is Shea. I'm a nurse practitioner here at the Arkansas Heart Hospital. I've been an employee since 2009. I was the nurse practitioner of the Congestive Heart Failure Clinic up until recently, and I transitioned to the Malvern Diagnostic Clinic for a more family practice approach in my career. Today, I want to talk to you about uncontrolled hypertension in the primary care setting. Let's start by defining hypertension. We know that this is a condition in which the blood force against the artery walls is too high. There are several risk factors that put us all at risk for getting hypertension throughout our lifetime, whether that's sedentary lifestyle, unhealthy diet, maybe it's genetics that all impact us. As clinical practitioners, we know that this is something that we talk about daily with each and every one of our patients to help them lead a healthier lifestyle and reduce their risk of cardiovascular events occurring throughout their lifetime. A few facts about hypertension. Cardiovascular disease is the leading cause of death worldwide, and hypertension is a single modifiable risk factor for us developing cardiovascular disease. In the United States, we know that heart disease and stroke are the leading causes of death, and hypertension in our population puts us at risk for those two things. We also know that half of all of Americans either are currently diagnosed with hypertension or are currently on antihypertensive medications. 1 in 4 of those adults are adequately controlled or reaching their blood pressure goal. As primary care providers, we do have some guidelines in which we can utilize to have an evidence-based approach to managing our patients' hypertension. You have the 2017 ACC/AHA guidelines versus the JNC8. You can't go wrong with either approach to the management of your patient's hypertension. The primary difference between the two guidelines basically boils down to just the numbers at which you start treatment or diagnose your patient with hypertension. The medications used for primary prevention or initial management of a patient with hypertension are the same. Let's talk about those agents through the ACC/AHA guidelines. When your patient has a normal blood pressure of 120/80 or less, you evaluate them yearly. They now say that a patient with elevated blood pressure or is considered to have elevated blood pressure if their systolic pressure is 120 to 129 and less than 80 on the diastolic. At this point, this is where we really preach our lifestyle modifications such as exercise, diet, smoking cessation, etc., and reassess them every 3 to 6 months to keep a close eye on them. The patient is considered a stage 1 hypertensive patient if their systolic blood pressure reaches 130 to 139 or they have a diastolic of 80 to 89. At this point, it is important for us to use the Ascbd risk calculator to assess our patient's 10-year risk of a cardiovascular event of occurring. This is a free app download to your phone and should be utilized routinely in your clinical practice. If your patient is greater than 10% on the calculation, we know that we need to be aggressive in the management of their care to reduce their cardiovascular risk. So if your patient is stage 1 hypertension, if they are less than 10% on your Ascbd risk calculation without history of current cardiovascular disease, diabetes, or kidney disease, we still preach the lifestyle modifications as our first antihypertensive regimen. If the calculation comes out and they are greater than 10% without CVD, diabetes, or kidney disease, we would want to go ahead and start medication therapy as well as incorporate the lifestyle modifications. They are considered stage 2 hypertensive if their systolic blood pressure is greater than 140/90. And at this point, a lot of times we will end up having dual therapy medications for these patients to help them reach goal. We reassess them monthly until we do have them at the goal, whether you're following the JNC8 guidelines or the ACC guidelines and the goals that they set forth. The primary agents, like I said before, are similar between the ACC/AHA guidelines and the JNC8. Thiazides, ACE inhibitor, and ARBs, and calcium channel blocker are your first-line therapies for any hypertensive patient. It is known that in African American population or your Black population that thiazides and calcium channel blockers are your first lines initially. To dive a little bit further into the pharmacological classes and their usages and avoidances, We know that thiazides are first line. You can use them in your heart failure, diabetic, or stroke patients. We would typically want to avoid them in patients that maybe have a history of gout, electrolyte disturbance such as hyponatremia or hypokalemia, and of course pregnancy. Your ACE inhibitors or ARBs we would use in your diabetic population as they are renal protective, as well as in your heart failure patients. We would want to avoid them in renal artery stenosis, a patient with a history of angioedema, and of course pregnancy. Your calcium channel blockers are also first line. You can use those in your patients that maybe have a history of Raynaud's syndrome as stroke prevention and any kind of tachyarrhythmias. We'd want to avoid them in patients with heart block, pregnancy, and heart failure. And with heart failure, it can lead to worsening exacerbation of their heart failure symptoms. And also in your GERD patients, so your acid reflux patients, be mindful that it can relax that lower esophageal sphincter and it might make their GERD symptoms worse. Beta blockers are not your first line agents, but I did list them here because they are commonly used in certain patient scenarios and with certain comorbidities, such as maybe they're a post-MI patient, they're a heart failure patient, they're utilized a lot in stage fright, maybe essential tremors, or even migraines that you see within your clinical practice. Obviously, you would avoid them in patients that are maybe bradycardic. COPD patients or asthma patients, be mindful of them and their beta selectivity. And maybe in a diabetic patient, we would want to be aware that beta blockers can mask our hypoglycemia episodes. Aldosterone antagonists are also not considered first line, but you will see them and utilize them throughout your clinical practice. These are commonly used in heart failure patients and patients with resistant hypertension. We would want to avoid them in patients that have a history of high potassium, as they do elevate the potassium level and they can cause gynecomastia. So let's proceed with our first case study. Mr. Cook is a 48-year-old white male who works as a chef with a history of type 2 diabetes and hyperlipidemia. He reports no new issues. He states he feels well, except his blood pressure at home has been consistently elevated at 140 to 150 over 80 to 90. His labs look pretty good. His A1C, though, is a little bit elevated. His blood pressure in office is elevated at 145 over 85, and his BMI is at 30, which is also elevated. His meds consist of aspirin, simvastatin, lisinopril, and metformin. You type in all of his information in your Ascbd risk calculator, and it comes out at 12.8%, which tells us that we need to be more aggressive in the management of his hypertension to reduce his cardiovascular risk factors. What choices can be considered initially for Mr. Cook? Would we start metoprolol succinate on Mr. Cook as a first-line therapy option? At this point, we would not. Like we stated earlier, according to the ACC, AHA, and your JNC8, beta blockers are not considered first-line therapy, and at this point, that would not be something that we would select for this patient. What about starting hydralazine? Hydralazine is also considered a second-line therapy, not first-line, so therefore we would not consider hydralazine. If the patient had heart failure, especially an African-American patient that had heart failure, hydralazine would be a good medication to add on board. How about adding Hctz, which is a thiazide diuretic? We know that thiazides are considered first line. He already has lisinopril on board, which is your ACE inhibitor, and is renal protective for his current diagnosis of type 2 diabetes. Putting the Hctz into a combo format with lisinopril would aid compliance for him, as well as give him further blood pressure control. So that would be a fantastic option for this patient. What about starting amlodipine, 5 milligrams once a day? That would also be a viable medication to start as initial therapy for this patient. You cannot go wrong with either the Hctz or the amlodipine, however you and your patient choose to navigate their plan of care. Case study number 2. We have Mr. Smith, is a 55-year-old African-American male presenting for routine follow-up in your office. He was diagnosed with hypertension 1 year ago and is currently taking Hctz. He previously did not routinely check his blood pressure at home, and at the last office visit, his blood pressure was 145 over 89. You advised him to go home and monitor his blood pressure and follow up with you in 4 weeks, and he presents today with that blood pressure log. You take a look at his log, and you realize that the averages of his blood pressure are not where they need to be. They're still elevated. His blood pressure in office is elevated at 155 over 83. and his BMI is 30, so he is a little overweight. His current meds include Hctz and simvastatin. His labs were unremarkable, and his physical exam is unremarkable. You calculate his Ascbd risk, and he's at 10.5%, telling us that we need to be more aggressive in his medications to help further, or to reduce his cardiovascular events in the next 10 years. So where do we go from here on Mr. Smith? Would we consider adding amlodipine, 5 milligrams once a day to his regimen? If you think back to our guidelines, the primary agents utilized in an African American population are your thiazide diuretics and your calcium channel blockers. We know that amlodipine is a calcium channel blocker, therefore would be a good adjunct to his therapy to help control his blood pressure. Would we consider initiating valsartan as an ARB for his therapy? We could. At this point, I would stick with the amlodipine as being first line, but it can definitely be your third line therapy if he continued to have uncontrolled hypertension. Would we start metoprolol succinate or start clonidine? Those two are second line therapies, are not considered initial therapy, so I would avoid those at this point in time. Case study number 3. Miss B is a 72-year-old white female with a history of congestive heart failure with a reduced ejection fraction, coronary artery disease, and she presents today with elevated blood pressure of 160/90 per her home report. Her vital signs are elevated today in office with a blood pressure of 158/66. Her labs are pretty unremarkable with stable electrolytes and renal function. Her meds include carvedilol, Entresto, and Lasix, and several others. What are the best options to consider for blood pressure control for Miss B? Let's take into account that she has heart failure, and at this point, our therapy does kind of stray away from our standard ACC, AHA, JNC guidelines. When we want to think about the patient's comorbidities and the impact on their overall health, we would start trending towards the heart failure guidelines and helping us manage not only their heart failure, but their hypertension. And fortunately, all of the evidence-based medicines that are approved to help heart failure also help lower the blood pressure. To start off with, would we consider switching carvedilol to atenolol? If we know anything about the evidence-based medications for heart failure, there are only 3 evidence-based beta blockers to help us manage heart failure that consist of carvedilol, metoprolol succinate, and bisoprolol. So switching to atenolol would not be an appropriate option for this patient. We would keep her on her current carvedilol dose. Maybe we would consider adding spironolactone. We know that this is an aldosterone antagonist, and it is considered as first-line therapy or one of the first-line therapies in a heart failure patient. And unfortunately, it also helps treat resistant hypertension. So adding spironolactone is a fantastic option for Miss B. Would we start losartan? Well, if you know anything about Entresto is an evidence-based medication for heart failure that consists of sacubitril, valsartan, and valsartan is the sister to the losartan. So we would not start losartan at this point in time. Had Miss B come to you without being on Entresto or any other ACE inhibitor or ARB, adding losartan would have been a perfect option for her. What about considering starting the amlodipine, the calcium channel blocker? If you'll refer back to the previous slide on usages and avoidances, we said that we limit our usage of calcium channel blockers in heart failure patients. And the reason for that is they tend to worsen or exacerbate their symptoms. It is not contraindicated, but it's definitely not one of the front runners that we utilize in their therapy. So as you can see here with this case study, our game plan changes based on the patient comorbidities and her heart failure diagnosis and the management of her blood pressure. This is where your beta blockers and things come first line. Your ACE inhibitors, ARBs, or even the Entresto, which is considered an ARNI, are your first line agents. But things like calcium channel blocker, we move it to later on in the game. So resistant hypertension. This is a persistently elevated blood pressure of greater than 140/90 in a patient that's currently on 3 or more antihypertensive medications. Always consider pseudo-resistance in your patients that have resistant hypertension. This happens about half the time with our patient population. It consists of maybe poor blood pressure measurement technique, maybe the wrong size fitting cuff, non-adherence to the medication regimen, or maybe their medications aren't up to par just yet. And also consider white coat effect. If you deem that your patient is truly having resistant hypertension, you always want to screen for secondary causes, such as renal disease, primary aldosteronism, sleep apnea, or maybe some drug-induced type hypertension. So let's lead into case study number 4, and this is our last case study. We have Mr. Complex. He's a 55-year-old African-American male presenting for follow-up of his hypertension. He has a history of coronary artery disease, hyperlipidemia, and type 2 diabetes. Over the past few visits, his blood pressure remains consistently elevated at 160 to 170 over 80 to 90. He states he is compliant with his meds, he's exercising regularly, and he's following a low-sodium diet. However, he does report some persistent fatigue. His vital signs showed his blood pressure is a little bit elevated at 142 over 92. His current meds include amlodipine, losartan, Hctz. So he's got 3 antihypertensive medications on board. And at this point, we need to figure out how we can help his resistant hypertension to help further reduce his risk of a cardiovascular event of occurring. So what are our next steps for Mr. Complex? Would we consider switching losartan Hctz to losartan plus chlorthalidone? This is a very much viable option, as chlorthalidone has been proven to be more efficacious and more potent than the Hctz. The downside of this is he is going from a combo used pill to 2 separate medications. So in a non-compliant patient, that might not be a good, reasonable option. Could we consider adding spironolactone, our aldosterone antagonist? We know that these are used routinely for resistant hypertensive patients, so it's a great fourth-line agent to add on for Mr. Complex. Would we want to investigate his persistent fatigue a little bit further? We definitely could. We could send him for a sleep study to see if there's any underlying causes or secondary issues causing his resistant hypertension. He's also on meloxicam for arthritis or osteoarthritis. Would we want to consider discontinuing the meloxicam? We know that that's an NSAID, and NSAIDs can raise blood pressure in even normotensive individuals. So finding an alternative therapy there for him would also be beneficial in lowering his blood pressure. So all of those options, they do not all have to be done simultaneously, but they're all great options in helping you manage the care of your patient. So you send him for a sleep study, and it comes back that he had severe obstructive sleep apnea, and now he's on a CPAP. And his blood pressure is well controlled, and he's averaging 130s over 80s, and you're pleased to see that. Had he not had sleep apnea, we could always circle back to the other options that we've listed, such as discontinuing the meloxicam or adding the spironolactone as a fourth-line agent. Considerations: always inquire about medication adherence or side effects. Reassess your patients monthly until they're at goal, and then every 3 to 6 months thereafter. Most patients are going to require more than one medicine to reach their blood pressure goal. Thank you for your time and attention.
So if this interests you, please join us for the Heart Summit. Go to our website and you can register there for an all-day virtual experience. Thank you very much.